Madam, thank you. Nice. Madam. Just one doubt regarding every one of us. While we treat a child of febrile encephalopathy, the child comes to us seizure already to the during the time of admission. So we are in a dilemma when to do the E. Because we have already started the valproate or phenytoin or levetiracetam. So as you told, we need to do the EEG in certain situations. In this situation, where we have started the treatment, what is the guideline or recommendation to do the EEG at the earliest?
First of all, the EEG availability is very important. So we do usually at our centers we don't get EEG, or even if we get a EEG, that is only for an half an hour. The ideal would be whenever a child is admitted in PICU with a febrile status, as you have said, multiple, you should have a continuous EEG monitoring. Ideally, you should have a dedicated EEG machine for the baby. You should monitor the baby for next 12 to 24 hours. So once you have seen once there are no visible seizures present, the child is in as early as possible. You should get a EEG to rule out the electrical because electrical seizure as early as possible, and it should be a prolonged EEG. So not getting it for 30 minutes or 40 minutes is important. Whenever you are treating a seizure, you should have a prolonged EEG. It should be you should be able to get a burst suppression on EEG and then no. Basically, if the seizures are controlled, they will not have any effect on it. Look, EEG, what we are doing is we are just looking, it is helping us in the diagnosis. And for treatment point of view, it will only help us in this thing. So if you are given a drug and the seizures are controlled, the EEG will be normal or there will be a burst suppression. So in spite of your drugs, if there is an electrical seizures which are present, it gives you a thing that you have to increase the drug and you have to see whether you are diagonal.
Thank you very much.
Sincerest thanks to our esteemed moderator and panelists for enlightening us on fever with autotherapy. Now,
Yes.
We shall be felicitating the this session moderator and the chairperson and the previous session now. So I request all the faculty, panelists, moderators and chairpersons to please come on backside of the chair. We'll be doing the felicitation there so that we don't waste time away. Thank you.
handing over the proceeding to our MOC, Dr. Curie.
Morning everyone. So we'll be starting on the next session, National Tuberculosis Elimination Program. When it comes to India, we are still 28% of the tuberculosis cases. Even Amita Bachchan is not safe from it. So we all have to learn it along with it. And this is an effort from your side. It was previously known as RNDCP. Let me get on my website. Dr. Ali Raja and Dr. Jagdish. I request our chairperson, Dr. Ali Raja and Dr. Jagdish. Dr. Ravi Raja sir is the senior consultant pediatrician at Sehat Children's Hospital since 20 years, and Dr. Jagdish Kamar is a senior pediatrician from Mehsana, president-elect AOPG. Handing over.
Now, moving ahead from panel discussion to lecture mode, and the lecture mode, chairpersons of luxury and less workload. We have two lectures. We have two lectures in this session, and one of them is taken by our local gem, and he requires no introduction. It is my great pleasure to invite Dr. Manish Mehta to introduce Manish without his print. We all have seen Manish evolution from a sincere, hardworking pediatrician since the inception of Synergy almost 15 years back, to great academicians in several years these days, and a speaker of a great caliber. He has served UP Ahmedabad and UP Gujarat at different posts. He has played key role in organizing different events, including this one. More importantly, his passion for academics has made him a leader in different modules of Sector IAP and National Tuberculosis Elimination Program is one of them. So we have no better one to speak about TB on this topic and hand over to you, Manish. You have 25 minutes.
Thank you, sir. First of all, for the kind introduction. So, on behalf of Guj Pedicon team, first of all, I welcome you, all of you, to this 2 days academic feast of Vexi Adicon 2024. Here we have excellent faculty of national deputy from different parts of India, except me, and I'm sure you are going to get enlightened from all of them in next 2 days. So, whenever it comes to tuberculosis, we all think, oh, TB to हमको आता है. We see daily cases, fever, cough, not gaining weight, recurrent illness, X-ray में कुछ pneumonia आया. So it is tuberculosis. So you are right. It is tuberculosis. Am I audible? Yeah. So it is tuberculosis. But what NTP has done, it has organized this module in such a way it makes the management, diagnosis, and treatment of this tuberculosis a very simple way. Like whenever you go through this NTP multiple times, it will come into your practice to manage your patient of tuberculosis like that only. Normally, what we do, a patient comes 6 to 7 times in the last 6 months, recurrent illness, fever, cough, थोड़ा weight के नहीं हुआ है, तो ill child है, कोई great grandparents को tuberculosis था family में, let's start on again. So now things have changed, and legally also we are supposed to follow this model because this is a central model along with government of India. So if you divert from this model, you take your clinical acumen to manage the patient. It may not be correct, and you may be sued in the court of law if you have not managed your patient in a proper way. So let's start with this. By the time they arrange all these things, we'll start with the module. So NTP, what is NTEP? Many of us would have attended this NTP module in the past. So in 2019, what WHO has done, they have given this NTP module, and the purpose was to eliminate tuberculosis. Like how the 90% reduction in the death due to tuberculosis and 70% reduction in the incidence of tuberculosis. That was the target of WHO. But अपने मोदी साहब उससे भी आगे निकल गए. उन्होंने कहा कि हम 2030 तक वेट नहीं करेंगे. We'll eliminate by 2025. But the problem came is COVID. So 2 years are wasted in the COVID. So now, right now, because of lack of vaccination, all these things, we are seeing lots of new cases of tuberculosis. So probably it looks difficult at present to eliminate by 2025. But the role of all of us is very important to get this target of elimination of tuberculosis by 2025. So what's new in this? There is nothing new in this. We are doing all these things, but we'll do in a rationalized way. And one new thing that has been added is CBNAT that we'll see in our slides. So let's first define a case of tuberculosis. What do we consider as a tuberculosis? When is suspected tuberculosis? So gone are those days like this is a suspected case of tuberculosis? No. Now you have specific criteria when you suspect a patient having tuberculosis. So what are these? First of all is fever. Fever of more than 2 weeks. Now, what some of the patient comes to us for 15 दिन से बच्चे को बुखार आ रहा है 15. So it's not like you have to just take the 15 days fever. There should be documentation of fever daily, at least once, more than 99. So it should be non-remitting fever. There should be no period of fever, period of 2 to 3 days in between. 5 दिन fever आया, 2-3 दिन नहीं आया, फिर वापस 5 दिन आया. So that is not a non-remitting fever. So non-remitting fever for more than 2 weeks. Second is non-remitting cough. This is very common symptom in OPD practice. 15 दिन से बच्चा खांस रहा है, महीने से खांसी आ रही है, but it's not like that. So 15 days of non-remitting cough. There are no vaccine wearing periods. It is continuous non-remitting similar type of cough for 15 days. Third criteria is your weight loss. So more than 5% of weight loss in last 3 months period, or there is no weight gain in last 3 months in spite of good nutritional rehabilitation in a patient of malnutrition. So these are the 3 main criteria, and along with that, history of contact with tuberculosis in last 2 years. Each and every word of these criteria are very important. So last 2 years history of tuberculosis contact Okay. So history of contact in last 2 years. So if someone says my grandmother had tuberculosis, but that was genital tuberculosis. So does it matter that contact is matter? Yes, because there may be a silent pulmonary tuberculosis along with that. Primary tuberculosis may be in the lung, and that may still be a person who can transmit this infection to the child. So contact is very important, whether it is pulmonary or extrapulmonary tuberculosis. In children, problem is most of the time extrapulmonary tuberculosis is much more common than pulmonary tuberculosis. So we have to see for peripheral painless swelling, lymph nodes, spine gibbous, incidence onset meningitis, or any non-specific symptom with a contact with TB patient. So if a child has history of contact with tuberculosis patient and there are no classical symptoms above mentioned, still we have to think of tuberculosis if there is a history of contact. So these are the criteria on which base we will suspect tuberculosis, not diagnose. We will just suspect tuberculosis. Now, why it is difficult to diagnose tuberculosis in children? Because we all know there is a possibacillary disease. So number of tuberculous bacilli in the sputum are very less. One thing. Second thing is to collect the sample. In children, to collect sputum sample is very difficult. To convince parents for gastric lavage is also an issue. And so the diagnosis to confirm microbiological confirmation of tuberculosis is very difficult in children. So that's why the difficulties arise when you want to confirm the diagnosis of tuberculosis in children, especially. In adults, definitely you can get sputum. Classical X-ray findings are much more common in adults. In children, you don't get the classical X-ray findings of tuberculosis. So it's a possibacillary disease. So difficult to diagnose and difficult to get the sample. That's why pediatric tuberculosis is very difficult to diagnose. Second thing, investigation. If you say culture is only 45 to 55% of sensitivity to diagnose the tuberculosis. So again, 50% of cases are missed if you follow culture also. And if you compare this culture with our tests which are available, smear and CBNAT. So they say CBNAT is 90% sensitive among culture positive tuberculosis, and smear is only 40%. So smear is very less positive because of possibacillary disease. CBNAT is the only test we have available to diagnose most of the cases of tuberculosis. And good thing about CBNAT is very specific. False negatives are very less. So that is a good part. Whenever you have positive CBNAT, it is pakka case of tuberculosis. You don't have to think anything else. But if you have negative CBNAT, you cannot rule out your tuberculosis. Let's see a case. 4-year-old child, 12.8 kg, BCG vaccinated, unremitting fever for 20 days, mild cough for 3 weeks, not eating well, history of tuberculosis to grandmother, currently on AKT, smear negative tuberculosis, and when contact case becomes non-infectious. So here there is a classical history, fever, cough, everything is there, history of contact is there. As I told you, there can be contact can have non-pulmonary tuberculosis, but still it is considered as a contact. So when this contact becomes non-infective, if there is a contact in the history is there, they say for 5 years back grandmother had tuberculosis and she started AKT, or maybe 2.5 years back she was on AKT, she started on AKT. So what is the duration of AKT that makes this contact non-infective? When they become non-infective, so what is the duration? So they say 2 weeks. In drug sensitive tuberculosis it is 2 weeks, but if it is MDR TB it may be 1.5 to 2 months to become non-infective. So we have to remember that part. So here we suspect this is probably a case of tuberculosis. What next investigation? What NTEP says? What should be the next single investigation that you perform in this patient? CBC, ESR, CRP, Mantoux test, chest X-ray, sonography. What will you do? Chest X-ray. Chest X-ray is the only investigation they say you should perform first when you suspect a case of tuberculosis. So this is a presumptive case of tuberculosis. We have not confirmed this case as a tuberculosis yet. So X-ray will have multiple findings. So what are the X-rays? This is our patient's X-ray. What does it suggest? What is it? Yeah, so there may be some consolidation on the left side. So is this tuberculosis? So this can be, this may not be. Okay. So what? Yeah, so it is still continuous suspected. Okay, so what are the X-rays that will suggest this is tuberculosis? There are 3 X-rays they say that suggest it is tuberculosis. One is your fibrocavitary. So if there is a thick wall cavity with fibrosis, it is a tuberculosis. If there is a miliary tuberculosis, then it's a tuberculosis. And what is the third one? Hilar. When there is a hilar node, primary complex. So they say only these 3 X-ray we consider in the category of tuberculosis. non-homogeneous opacity, consolidation, thin wall cavity, only pleural effusion, they are not suggestive of tuberculosis. We may have to investigate these cases further. So if our child would have this X-ray, then it is tuberculosis. We should start AKT on this. Yes or no? No. Good. So what will you do? What should be done? So yes, so micrological confirmation is most important. Why it is important? Why you should confirm? This classical miliary tuberculosis, classical history is there. Why do you want to confirm? Exactly. So it is not only for diagnosis, it is to check whether this is rifampicin sensitive or rifampicin resistant tuberculosis. So that's why we always do micrological confirmation. So what are the tests that are used for micrological confirmation? So WHO has advised specific tests, almost all PCR based tests. They are approved by WHO. These are rapid diagnostic tests for tuberculosis. Why rapid diagnostic? Because turnaround time is hardly few hours. You get your report in few hours, 2 to 3 hours probably. So that's why they have advised this test to be performed in a case of tuberculosis. Our child has this X-ray. What will you do? Child has come to you, got an X-ray. What will you do this for this child now? You will go for directly sampling. No, you will give a 7 days trial of antibiotic first. Which antibiotics to be used? Which antibiotics not to be used? Yes, everyone knows. So linezolid, levofloxacin are not supposed to be used. So fluoroquinolones are to be avoided. Azithromycin, most important, should be avoided because they are the drugs reserved. Macrolides are the drugs reserved for resistant tuberculosis. One thing. Second thing, they will have partial action. The child will improve partially, and you will miss the tuberculosis. So amoxicillin or at the most amoxiclav will be a drug of choice to treat this child for 7 days. If the child has received antibiotics somewhere else in the past, in last few days, then you can avoid this, skip this test, and you can directly go for the investigation. So what are the tests that are used for this diagnosis of tuberculosis? WHO has approved few tests. CBNAT is the, we all know, is the most commonly used test. What are other? That is line probe assay. That is also a kind of PCR, but it's a slow process. Extraction, amplification, and isolation are different processes in this. So it takes around 2 to 3 days to get the report. In CBNAT, all these things are done together. So you'll get report in 2 to 3 hours. Good thing is this expert MTB or RIF ultra. This is very sensitive test. Normally in CBNAT, you can diagnose a case of tuberculosis if there is more than 131 bacilli per ml. But here it is 16 only. So it is highly sensitive. But the problem is, as it is highly sensitive, chances of false positives are there. Because non-viable bacilli can also be diagnosed in this. Even a few number of non-viable bacilli are there, this test will come positive. So in India, it has started at few places, but still, in general, we use CBNAT only for diagnosis of tuberculosis. And last is TB lamp, that is used mainly for sputum. In sputum, we test TB lamp, that is again a PCR test only. But as we have possibly disease in children, this test is not much useful in children. So what are the samples that we can send for CBNAT? Everything whichever you can take except for blood. So that is most common is sputum. If you don't get sputum, you can collect the sputum by ball or induced sputum. Okay. So if you are sending a ball or induced sputum, you can do smear, you can do CBNAT, and you have to do culture. These three tests you have to perform whatever sample you are sending. Why? Smear, very low positivity rate, but early diagnosis. Other bacteria can also be diagnosed on smear. You could do gram stain along with AFB. Problem of smear, non-tuberculous mycobacteria will also be AFB positive. So plus don't give any sensitivity pattern. So it is only for screening method. It cannot be used for confirmation. Second is your CBNAT, that will give straight away your diagnosis and rifampicin sensitive or resistance. And third is culture. This culture is very important. Previously you used to do solid media culture, that is LJ medium, which used to take few months to get the report. But right now we have liquid media culture, that is MGIT, that is mycobacterial growth tube indicator test, which gives results in 2 weeks, 2 to 3 weeks. Why this is to be done? Because CBNAT will only test sensitivity or resistance to rifampicin, but this MGIT will give you resistance against isoniazid also, which is also increasing nowadays. So MGIT is must. Plus we have seen cases where CBNAT is negative, probably not collected sample properly or whatever is there, but MGIT comes positive after 2 weeks, which will help in the diagnosis of tuberculosis. So all three things have to be confirmed, not only CBNAT, which whatever sample you send. So sample can be BAL, induced sputum, your pleural fluid, your CSF, your tissue biopsy. They say yield from tissue biopsy is much better than any of the fluid. So if you are a patient of pleural effusion, we all know it is a hypersensitive reaction. It is not primary tuberculosis infection in the pleural fluid. So pleural fluid yield of CBNAT is very poor. But if you send pleural biopsy, if you have done some procedure, if you can send pleural biopsy and do CBNAT, this will be positive in spite of pleural fluid being negative for the CBNAT. So that is very important. BAL, definitely if your child is intubated or if you're suspecting a pneumonia which is not improving by any means and you go for bronchoscopy, then BAL will be a good sample to send for CBNAT. So these are the samples you send for the CBNAT. Once you have the report, so what is CBNAT? So it is very high sensitivity, as we told, 131 per ml bacilli, more specific, no cross infection or contamination. So it is a closed technique. Once the sample is collected, the sample is not opened anywhere, it is directly put in the machine. So chances of infection of a lab personnel is very low, chances of contamination are very low. So it's a really good test and it gives you rifampicin resistant upfront. So hence a negative CBNAT does not rule out TB, because as we discussed, 90% and 30% of CBNAT and smear compared to culture positivity, and overall yield in respiratory specimen is not that great, and MDP culture has a sensitivity about 45 to 50%. So culture is only 45 to 50%, 55% sensitivity. So this is the issue with the diagnosis. This is another test that we described already, very sensitive. Advantages are highly sensitive, 16 bacilli per ml can also detect tuberculosis, possibly disease, and negative is false positive. Because of the non-viable bacilli can also be diagnosed because it is very highly sensitive. TrueNAT, this is like point of care test. It's a portable machine that can be taken anywhere. Ultimately, system is same, PCR based only, but the problem is it can test one sample at a time. So use in a community will consume you lots of time. So this is also being available in India. So in our case, ZN stain was negative, CBNAT 2 samples of gastric. So here important thing is how many samples you should send. So if you are sending for smear, that should be 2 samples collected different time. Duration is not important, but 2 samples have to be collected. Like if it is gastric lavage, it is not important you collect one today, one tomorrow, or 24 hour per 12 hours. It's not like that, but it's to be collected at different times. Okay, then, or if you are sending CBNAT, that should be a single sample. Okay, if your first CBNAT is negative, your smear is negative, 2 samples, what will you do? Will you leave this case or will you treat this case? Yeah, so look for other sites from where you can collect sample. Look for the better sites. If you have some lymph node there with the child, you can send the sample of the lymph node. If you have some fluid is there, you can send the sample of fluid. Some tissue is there, you can send pleural biopsy also. So other better quality specimen you should try to send if your first CBNAT is negative. Don't perform same CBNAT from the same sample again. Smear 2 sample, CBNAT single sample. If your CBNAT has come negative, what will you do? You will try for the better sample. If it is positive, treat as tuberculosis. If it is still negative, if you have put in every effort to diagnose all the tissue biopsy you have sent, lymph node, everything you have sent, still your CBNAT is negative. But if you strongly feel this is a tuberculosis, then only you can treat this child as clinical diagnosed case of tuberculosis after doing all this homework only, not before that. So you put all your efforts and child is not improving, not confirming the diagnosis, then only you can think of clinically diagnosed case of tuberculosis, and you may need to take some expert opinion like Dr. Baldev Prajapati sir, Dr. Satish Pandya sir, Dr. Abhay Shah sir before starting, because see, legally things are going to come in this tuberculosis, because most of the tuberculosis medicines are not available now in routine medical stores. So government is only going to be the place where tuberculosis medicine are going to be available in future, and they have specific combination of the drugs and that are going to be very useful. So ultimately you have to refer, you have to notify this case to the to the government, and there may be a scrutiny from the government how you have diagnosed this patient. So your everything work should be very clear before confirming or starting the treatment of tuberculosis. Our favorite tuberculin skin test. पेशेंट 15 दिन से कफ है, फीवर है, सबसे पहले टीएसटी करा लो. अगर वो पॉजिटिव है तो कुछ सोचेंगे, नहीं तो भूल जाएंगे. तो व्हाट आर द प्रॉब्लम्स विद टीएसटी? फर्स्ट ऑफ ऑल, व्हाट इज पॉजिटिविटी? मोर देन 10 mm. 2 T unit should be used. 0.1 ml intradermal, we all know, reading after 40 to 72 hours. So what are the problems? So first of all, it diagnosis of infection and not the disease. So if his latent TB infection is there, MT will be positive, but child may not have the disease. One thing. Second thing, presence of HIV, malnutrition, this will have false negative taste of MT. And third thing is, now they say the stock of tuberculin fluid is also getting exhausted with time. So in future, it may not be available to us to do the test. So we need some better test to perform rather than tuberculin test. So what is that? What is, so positive will not also have value, negative will also have doubt. So it's difficult to interpret on the base of, yeah, a problem. So when this test will be important, if your child has all the symptoms, you have done all the homework, but all CB net and everything is coming negative, but your tuberculin test is strongly positive, then that will be an additional help to confirm your diagnosis of tuberculosis. Otherwise, only this test based on only clinical history, it will not be much helpful. Okay. So what is better test? That is one new test that is coming up. There is CTB, new kid on the block. So what is CTB? CTB is almost same as MT test, but it uses antigen. So it is more sensitive and specific compared to the MT test. More than 5 millimeters positive, same 0.1 ml intradermal. Cost test is very low, 30 to 40 rupees. So it is not very costly also. Reading again after 48 to 72 hours. But the problem which was there with MT, that your HIV, malnutrition, immunodeficiency was going to affect your report. This will not get affected by those things. So diagnosis will be better. Another test is IGRA, that is interferon gamma radioimmunoassay. Release a radioimmunoassay. So that is a blood test. You take a sample of the patient and you test the level of interferon gamma. They say this is being released by a tubercle bacilli. So high level of interferon gamma will confirm your, so that is quantiferon gold. So that is more than 2000 rupees, and still again sensitivity and specificity are not that great. So we should stop using this test if we are using. So CTB is being started in few parts of India, and probably soon we'll get this test available everywhere. So here our patient has TST of 18 by 15 millimeter induration positive. What is the significance? As we all discussed, incompatible clinical features and suggestive X-ray finding positive TST increases the specificity and useful supportive evidence for clinically diagnosed case of tuberculosis. Which are other tests you should perform? Always perform HIV in a case of tuberculosis. ESR, not much role. And ADA, forget this test. We always advise pleural fluid ADA. High, that means tuberculosis. So it is high in very many other infections also. So no meaning of performing ADA test in the pleural fluid. So this is the algorithm. Suspected case of tuberculosis, first go for X-ray. X-ray is suggestive of tuberculosis, go for NAT. NAT positive, treat. Okay, X-ray is not suggestive, give antibiotic trial if not given previously. Those 3 antibiotics are to be avoided. And if there is persistent shadow after 7 days of antibiotic, then again go for NAT. NAT positive, treat. NAT negative, try for another sample at good place. If still not getting, try to gastric lavage, induced sputum, all these things you have done and everything is there. And still you suspect is a strongly case of tuberculosis, treat as clinical diagnosed case of tuberculosis. Otherwise, refer to expert. Okay. Yes, yes. That's why I told 4-5 names also. So lymph node tuberculosis. This is very common that we see in our day-to-day practice. So if a child comes with a lymphadenopathy.
3 minutes.
Last
3 minutes. 3 minutes.
So lymph node, like it's a very commonly we get. So there are two types of lymphadenopathy we may get. Classical cold metal lymph node with abscess formation. Directly go for FNSE. Go NET, positive, treat it. Negative, then again all those things, your ball and everything and all those things. If it is not classical, then give antibiotic trial. If no improvement, then again go for all these tests, and if positive, treat as, otherwise clinically. That's you all know. Now treatment. What is new in treatment? The best thing that has come is in the treatment. There is a single regime for all cases of tuberculosis. Whether it is newly diagnosed, retreatment cases, it is pulmonary, it is extrapulmonary, same 2-HRZE plus 4-HRE, except for bone and joint and in neurological, where your maintenance phase is of 8 months instead of 4 months. Okay, so 2-HRZE plus 4-HRE, drug doses are slightly increased, so that you can get from all the literatures. But good thing is, one thing is important: if it's a retreatment case or treatment failure case, just check for drug resistant tuberculosis first before treating this child. Okay, so that is very important. There are fixed drug combinations that are available with government according to the weight of the child. So it has been always a problem to prescribe tuberculosis drugs in a patient with 10 kilo, 12 kilo, 15 kilo. So there are fixed drug combination available. You can just prescribe 1 tablet, 2 tablet, and things will be taken care of. And one important is DILI, that is drug induced liver injury. We are always worried about hepatitis following starting AKT. So in routine cases, you don't need to screen patient for SGPT when you start anti-tubercular drugs. But before starting drugs, you can just once check SGPT, then continue with medicine. If child gets develop symptoms of hepatitis like abdominal pain, vomiting, and icterus, then you investigate. If it is more than 3 times, SGPT is more than 3 times with symptoms, or more than 5 times without symptoms, stop your first line drug, start ethambutol, levofloxacin, and then wait for, and every 2 weeks, initially every 1 week, then every 2 weeks, check your SGPT level. Once it goes down less than 2 times, then you can start adding your drug. First add rifampicin, then isoniazid, and last is pyrazinamide. And whenever you are adding, again after 2 weeks you have to check. If it is again rising, then you have to go revert back. You have to add and remove in the same order which you have done previously. So more than 5 times without symptom, more than 3 times with symptoms, stop, start second line, 2 weeks, again check SGPT, better, start adding your drugs, rifampicin, isoniazid, and pyrazinamide. Why like this? Toxicity on the liver. Highest toxicity will be added the last, and least toxicity will be added the first. I think we are done. Pyridoxine, we all know 10 milligram is to be supplemented. Why? Because isoniazid is known to cause pyridoxine deficiency. If it is a drug resistant tuberculosis, you are using cycloserine and all these things, then dose will be 50 to 100 milligram. Okay. No need to supplement routinely multivitamin and all these things in all patient of. And one important thing is isoniazid prophylaxis therapy. Which patient are to be started on an IPT? That is all babies born to active TB during pregnancy, exposed to active tuberculosis during the newborn period, all household contacts of pulmonary TB patient, age less than 5 years, first rule out active TB, and then given more than 5 years, you can start straight. Along with that, you have to investigate for active TB also. An infant less than 1 year in contact with active TB, all patient living with HIV or child living with HIV should be started on isoniazid therapy. That is 6 months of isoniazid drug, that is 10 milligram per kilogram per day. There is another option of rifampicin with isoniazid combination is available, which is only 3-month course, and there is once a week therapy. So that is also available. So these are the things for tuberculosis. If any queries, sirs are there to answer. Thank you.
Thank you so much, Manish.